This crash course series highlights the classification and key features of common hematologic neoplasms. The topic can be particularly daunting, so this module is designed to help address frequently asked questions. My name is Brad Drumheller, and I did my hematopathology fellowship training here at Penn. I'd like to welcome you to this course, and I hope you enjoy. Before proceeding, please take this brief entry quiz to assess your knowledge. The quiz will take approximately 10 minutes to complete and is designed to reinforce the high-yield topics covered. Valuable in-depth feedback is provided upon submission to really help you master this material. The exit quiz follows the same format and is meant to test your understanding upon completion of this course. These questions are part of an academic educational research project, and as such, there is a brief consent explaining how your responses are anonymous. Please note that these quizzes utilize Google Forms, which may be blocked on a campus computer. This is due to a firewall affecting Google web pages. You should try accessing in a different location, on a personal device, or through a mobile hotspot. The video is divided into 6 short segments, starting with a broad introduction to blood cell development and ending with T-cell neoplasms. Let's begin by building a strong foundation. By the end of this section, you will be able to identify hematologic cells on histology, summarize the different pathways of hematopoiesis, and differentiate between leukemia and lymphoma. The classification of hematologic neoplasms is made with the combination of morphology, which is the appearance under the microscope, clinical presentation, and genetics. Keep in mind, many disorders we discussed are now being classified based not only on these features, but also by the molecular and cytogenetic alterations that drive the disease. Before we start, it's important to discuss some different sample types used to evaluate patients with hematologic neoplasms. The first type is a simple blood smear. A slide is made by applying a drop of blood and smearing it across the slide. 3 normal circulating components are white blood cells, red blood cells, and platelets. The quantity of different cells is compared to an age-adjusted reference range to detect any increases or decreases that may deviate from a normal population. The second sample type is a bone marrow biopsy, commonly taken at the posterior iliac crest. Typically, both a core biopsy and a marrow aspirate are taken to review the cellular elements and perform additional testing, which is outside the scope of this review. Lastly, tissue biopsies of a lymph node or another site can be performed to rule out involvement by lymphoma. These are often performed when a lymph node is found to be abnormally large. Lymph node biopsies are also important for diagnosing metastatic disease and for tumor staging. Great, now we have our samples. Let's review the normal components and their neoplastic counterparts. Human hematopoiesis, the production of mature blood cells, starts in the bone marrow with the pluripotent or multipotential stem cell, which is shown at the top of the diagram. This cell gives rise to an early progenitor cell, a stem cell restricted to the lymphoid and myeloid lineages. The lymphoid stem cell matures into B cells, T cells, and NK cells. The myeloid stem cell matures into all other blood cells, principally megakaryocytes, red cells, granulocytes, and monocytes. As marrow cells mature, they are released into circulation, where some ultimately reside in tissues. This is an important concept to grasp, since many hematologic diseases can be traced to a defect in the hematopoietic pathway. Here is another illustration highlighting the cellular morphology. Notice how the granulocytic, megakaryocytic, erythroid, and monocyte production all branch from the myeloid lineage. The mature cells spill into the blood and constitute normal counterparts on a blood smear. Mature lymphocytes are also found in circulation. Plasma cells are primarily found in tissues. Erythroid and myeloid pathways show analogous differentiation. As they mature, the cells get smaller, their chromatin condenses, and the cytoplasm changes. Granulocytes gain granules and red blood cells gain hemoglobin. The nucleus of granulocytes also becomes segmented. To learn more, you can check out Cell Atlas, a smartphone application with excellent pictures and detailed descriptions, which is referenced here. Now let's focus on hematologic neoplasms. It's important to define some terminology first. Leukemia is a neoplasm affecting the bone marrow and ultimately, because marrow cells circulate, the peripheral blood. Lymphomas involve tissues, often lymph nodes or spleen, the suffix "oma" here meaning solid tumor. In some instances, the neoplastic cells can involve both compartments. However, the nomenclature usually denotes the tissue of origin. For example, follicular lymphoma, which typically arises in a lymph node, is called follicular lymphoma, even if it involves the bone marrow. An exception to this rule is chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL, SLL, since this disease usually involves the bone marrow, blood, and tissues. Mirroring hematopoiesis, the classification of hematologic neoplasms can be divided broadly into lymphoid and myeloid disorders. Myeloid maturation occurs in the bone marrow and eventually involves the blood. Myeloid neoplasms, therefore, are mostly leukemias. Lymphoid neoplasms can arise early in maturation as bone marrow disorders, leukemias, or once B cells and T cells mature and leave the marrow for secondary lymphoid organs, as solid tumors, lymphomas. In other words, leukemia can be either myeloid or lymphoid. Lymphomas are generally lymphoid. By the end of this section, you'll be able to distinguish between acute myeloid leukemia and acute lymphoblastic leukemia lymphoma, identify the translocation associated with acute promyelocytic leukemia, as well as the treatment, and finally summarize the differences between the myeloproliferative neoplasms. Acute leukemia is caused by a neoplastic proliferation of immature marrow cells, or blasts. These neoplastic cells have two fundamental problems. They proliferate wildly, and they suffer from a differentiation block, meaning they can't mature. The result is an accumulation of immature cells, which then spills into the peripheral blood. The replacement and crowding out of normal marrow cells often leads to decreased normal mature cells in circulation, leading to anemia, not enough red cells, leukopenia, not enough mature white cells, and thrombocytopenia, not enough platelets. Blasts can be derived either from the myeloid lineage, myeloblasts, giving rise to acute myeloid leukemia, or lymphoid lineage, lymphoblasts, giving rise to acute lymphoblastic leukemia. Acute myeloid leukemia is a neoplastic disorder of immature myeloid cells, myeloblasts. The risk increases with age and is therefore more common in adults. Additional risk factors include a history of prior chemotherapy or radiation, benzene exposure, and Down syndrome. Patients present with symptoms related to marrow infiltration, including fatigue, anemia, bleeding, thrombocytopenia, and infection, low number of functioning white blood cells. An additional symptom is gingival hyperplasia, which is caused by an infiltration of leukemic blasts into the gums. Blasts may contain hour rods, which are pink cytoplasmic needle-shaped crystals caused by an abnormal fusion of primary azurophilic granules containing myeloperoxidase, or MPO. Acute promyelocytic leukemia, APL, is a unique subset of AML with a favorable prognosis. However, most patients initially present with a life-threatening consumptive coagulopathy, termed disseminated intravascular coagulation, abbreviated DIC. The leukemic cells produce excess tissue factor, which activates the coagulation cascade and creates tiny blood clots, called microthrombi. Platelets and clotting factors are consumed this way, giving rise to an increased bleeding tendency from multiple sites, such as the GI tract. Therefore, early recognition and treatment is critical. Histologically, blasts can contain numerous hour rods. The characteristic translocation is translocation 1517, involving the PML-RARA genes, or RARA. RARA is a retinoic acid receptor alpha gene, which may help you remember the important treatment, a vitamin A derivative called all-trans-retinoic acid, which is abbreviated ATRA. Acute lymphoblastic leukemia is a neoplastic disorder more common in children, with an increased risk associated with Down syndrome. In contrast to AML, blasts often express terminal deoxynucleotidyl transferase, TDT, and lack hour rods. There are two flavors of ALL with a propensity to present in different sites. B-ALL, arising from B lymphoblasts, more often presents in the bone marrow, with symptoms related to bone infiltration including decreases of mature cells in the peripheral blood and bone pain. T-ALL can form a thymic mass, T for thymic, with symptoms related to compression of surrounding structures. Myeloproliferative disorders are due to the uncontrolled proliferation of one or more myeloid cell lines, granulocytes, erythroid cells, and megakaryocytes, leading to an increase of mature progeny, neutrophils, red cells, and platelets, not blasts, in the periphery. Splenomegaly is usually present. While there is overlap between these diseases clinically, chronic myeloid leukemia, CML, is characterized mainly by the overproduction of granulocytes. Polycythemia vera, PV, is characterized by an excessive production of red cells, and essential thrombocythemia, ET, by an overabundance of platelets. A related disorder, myelofibrosis, affects megakaryocytes like ET, but has a unique natural history that won't be covered here. Each of these has the ability to transform into an acute leukemia, however the time course and likelihood are variable. Chronic myeloid leukemia is characterized by proliferation of granulocytes, resulting in an abundance of more immature forms spilling into the peripheral blood, such as promyelocytes, myelocytes, and metamyelocytes, producing a left-shifted leukocytosis, often with increased basophils. The characteristic translocation is translocation 922, creating the BCR-ABL fusion gene and forming the Philadelphia chromosome. Because the BCR-ABL fusion creates a powerful tyrosine kinase, treatment is targeted at inhibiting its activity with kinase inhibitors like imatinib. Polycythemia vera produces increased red blood cells. Symptoms may include pruritus, often triggered by hot showers, and those associated with hyperviscosity and thrombosis, in contrast to secondary polycythemia, which shows an increased erythropoietin level. Erythropoietin, or EPO, is normal or decreased in PV. Almost all cases have a JAK2 mutation. Note that JAK2 mutations can also be seen in roughly half of ET and PMF. Treatment is variable, but often includes aspirin and recurrent phlebotomy. Essential thrombocythemia manifests clinically with increased platelet production, leading to increased risk for thrombosis and hemorrhage. Secondary causes of increased platelets should be ruled out. About half of ET cases have a JAK2 mutation. Similar to ET, primary myelofibrosis is a disorder of megakaryocytes. However, unlike ET, PMF, like the name suggests, manifests with bone marrow fibrosis. This fibrosis wraps around the cells, making it difficult to aspirate, producing a so-called dry tap during a bone marrow biopsy. I'll briefly touch on one additional neoplasm termed myelodysplastic syndrome, MDS. MDS is a heterogeneous group of clonal hematopoietic stem cell diseases characterized by ineffective hematopoiesis. The key here is ineffective. Cells are actively proliferating, but incapable of normal differentiation and maturation, which results in hypercellularity and apoptosis in the marrow, and cytopenias in the periphery. These defects in maturation are associated with morphologic abnormalities, or dysplasia, which are listed in the table and illustrated in the graphic. The most common dysplastic features are hypogranular neutrophils, erythroid cells with multinucleation, irregular nuclear contours, or megaloblastic changes, and megakaryocytes with small, hypolobated nuclei or with widely separated nuclear lobes. Reactive or other neoplastic conditions may mimic dysplastic changes and should be excluded. These include nutrient deficiencies such as B12, folate, and copper, infection such as HIV, EBV, CMV, and parvovirus, chemotherapy and medications, toxins such as alcohol, heavy metals, and arsenic, autoimmune conditions, and some congenital disorders. Myeloproliferative neoplasms previously discussed may show morphologic overlap with MDS. CML has small monolobated or dwarf megakaryocytes, for example. Recurrent genetic abnormalities are also common. Patients with MDS are at increased risk of developing AML. By the end of this section, you will be able to outline B-cell development and maturation and summarize the different types of B-cell lymphomas. Lymphomas have historically been divided into Hodgkin and non-Hodgkin lymphomas. Hodgkin lymphomas account for approximately 20% of all lymphomas. Non-Hodgkin lymphomas account for the remaining 80%. These non-Hodgkin lymphomas are further divided into B-cell and T-cell neoplasms, with B-cell neoplasms being more common at approximately 85% and T-cell the remaining 15%. We'll first discuss B-cell neoplasms in the non-Hodgkin lymphoma category. A simplified approach to learning lymphoma classifications is recognizing the cells they arise from, the so-called cell of origin. Let's start with discussing B-cell development and associated lymphomas. The B-cell is part of the adaptive humoral immune system. Early B-cell development starts in the bone marrow, B for bone, as a hematopoietic stem cell. B lymphoblastic leukemia lymphoma, previously discussed, is the precursor B-cell neoplasm that begins at this early phase of development. Remember, B-ALL is TDT positive. Cells mature, turn off TDT, and leave the bone marrow. The naive B-cell is a mature B-cell which has not yet encountered an antigen. These cells eventually form primary lymphoid follicles and mantle zones in peripheral lymphoid tissues, such as lymph node and spleen. When naive B cells encounter an antigen in the germinal center, they further differentiate into centroblasts. This creates the dark zone of the germinal center. Centroblasts rapidly divide and differentiate into centrocytes, which occupy the light zone of the germinal center. During this development, cells undergo somatic hypermutation and class switching. B cells with decreased antigen affinity undergo apoptosis and are cleaned up by tingible body macrophages, and those with high antigen affinity are rescued from cell death, selection. Follicular lymphoma, Burkitt lymphoma, some types of diffuse large B-cell lymphoma, and Hodgkin lymphoma are thought to develop at this stage. After selection, B cells leave the germinal center to form memory B cells and plasma cells. Marginal zone lymphoma, subsets of CLL, SLL, and some types of DLBCL develop from this stage. Myeloma is also included here since it develops from plasma cells, but remember, myeloma is not considered a lymphoma. Here is a tissue section demonstrating a normal lymph node contained by a pink fibrous capsule. Notice on high power that the germinal center is polarized by a dark zone and a light zone with the surrounding mantle. The paler pink cells seen in the germinal center are tingible body macrophages, cleaning up those cells undergoing apoptosis. Again, we can see the outer fibrous capsule. Now we'll discuss the most important types of mature B-cell lymphomas. CLL, SLL is the most common adult leukemia, often occurring in patients over 60 years of age. It is often an indolent disease with slow but gradual progression and is associated with lymphadenopathy and hepatosplenomegaly. Lymph nodes show diffuse effacement with cloud-like proliferation centers. Patients have an elevated lymphocyte count with small fragile lymphocytes that are easily disrupted, resulting in smudge cells on peripheral smears. A complication is transformation to a higher grade lymphoma, most commonly DLBCL, which is called Richter transformation. Follicular lymphoma is the most common low-grade B-cell lymphoma in adults. Patients present with generalized lymphadenopathy. The disease often has an indolent, waxing and waning course, but may eventually undergo transformation into a diffuse large B-cell lymphoma, which carries a poor prognosis. Tissue sections demonstrate numerous back-to-back follicles, lacking tingible body macrophages, with loss of normal polarity. The characteristic translocation is translocation 1418, involving the IgH heavy chain and BCL2. Note that the heavy chain locus on chromosome 14 is involved in many other B-cell lymphomas. Diffuse large B-cell lymphoma, DLBCL, is a common aggressive lymphoma which can arise either de novo or after transformation from a more indolent lymphoma. There are many subtypes, and immunodeficiency is a major risk factor. DLBCLs arising within the germinal center, GCB type, have a better prognosis than those derived from non-germinal center or activated B cells, ABC type. DLBCL, like the name suggests, is characterized by diffuse sheets of rapidly dividing large cells on histology. Burkitt lymphoma primarily affects children and young adults. There are 3 variants of Burkitt lymphoma, with variable EBV infection rates. The endemic form is strongly linked to EBV and found in the malaria belt in Africa and Central America. The sporadic form is more common in the Western countries. The immunodeficiency associated form is found in HIV patients and seen in older adults. Histology shows diffuse sheets of medium-sized cells with numerous tingible body macrophages, which imparts a starry sky appearance. The characteristic translocation is translocation 814, involving the IgH heavy chain and c-MYC. The translocation is easy to remember since the B in Burkitt looks like an 8. Marginal zone lymphoma is divided into 3 subtypes: extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, MALT, nodal, and splenic. We'll focus on MALT lymphoma here. MALT lymphoma is associated with chronic inflammation at various sites, often associated with infections or autoimmune conditions. An important association in gastric MALT is with H. pylori infection. Interestingly, in the early stages, this neoplasm can actually respond to antibiotics and regress. Like other low-grade B-cell lymphomas, there is a risk of transformation to diffuse large B-cell lymphoma. A common translocation is translocation 1118, involving the BRC3 and MALT1 genes. Mantle cell lymphoma is an aggressive small B-cell lymphoma. Involvement of extranodal sites, including the gastrointestinal tract and Waldauer's ring, is common. The defining cytogenetic abnormality is translocation 1114, involving the cyclin D1 and the immunoglobulin heavy chain, IgH. Hairy cell leukemia is characterized clinically by splenomegaly and morphologically by small lymphocytes with ample cytoplasm containing fine cytoplasmic projections illustrated here. A bone marrow biopsy aspirate is often difficult to obtain since the infiltrating lymphocytes cause marrowfibrosis, resulting in a so-called dry tap. Such inadequate aspirate specimens are also seen in other diseases associated with marrowfibrosis, such as primary myelofibrosis. Neoplastic cells in hairy cell leukemia arbor mutations in BRAF. By the end of this section, you will be able to summarize the CRAB symptoms and recognize the laboratory testing important in plasma cell myeloma. Multiple myeloma is a common neoplastic proliferation of plasma cells. Remember, plasma cells are responsible for making and secreting antibodies, also known as immunoglobulins, and these clonal plasma cells overproduce the same homogeneous immunoglobulin protein. The risk for myeloma is highest in the elderly, African Americans, and men. The diagnosis requires a combination of clinical, laboratory, and radiographic information. Myeloma is multifactorial and causes lytic bone lesions and predisposes to fractures. Osteoclast activation leads to hypercalcemia. The secreted immunoglobulin proteins cause renal casts and kidney failure. Marrow replacement and renal failure lead to anemia. Peripheral blood smears may show long chains of stacked red blood cells, termed rouleau formation, and sometimes circulating plasma cells, pictured here. Serum protein electrophoresis, SPEP, in normal patients shows a smearing pattern of polyclonal immunoglobulins. In myeloma, the monoclonal protein creates a distinct band on SPEP, abbreviated M protein. Immunofixation is a technique to determine the type of immunoglobulin and the light chain class secreted. In this case, a band is seen at IgM and lambda, indicating secretion of a monoclonal IgM lambda immunoglobulin protein. By the end of this section, you will be able to recognize the difference between Hodgkin lymphoma and non-Hodgkin lymphoma, describe how classic Hodgkin lymphoma is different from other B-cell lymphomas, and name the cells associated with classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Hodgkin lymphomas are distinct from non-Hodgkin lymphomas. Hodgkin lymphomas follow a contiguous lymph node distribution, while non-Hodgkin lymphomas are non-contiguous, meaning they don't follow a chain of lymph nodes. Hodgkin lymphoma does not have a leukemic phase, and therefore does not involve the peripheral blood. Hodgkin lymphoma is divided into two distinct types, classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Classic Hodgkin lymphoma is a special type of B-cell lymphoma. Recall that classic Hodgkin lymphoma arises from the germinal center B-cell, but downregulates expression of some normal lymphocyte markers, such as CD45, and normal B-cell markers, such as CD20, and expresses unusual markers like CD30 and CD15. It follows a bimodal age distribution, with a higher incidence in younger patients, and then again in older patients. There is an association with EBV infection, as well as immunosuppression. The malignant cell is called the Reed-Sternberg cell, with the characteristic binucleated owl eye appearance. These cells often attract a background of mixed inflammatory cells rich in eosinophils, lymphocytes, and histiocytes. There are four histologic subtypes: nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted, but these histologic distinctions are not nearly as important as the extent of spread or the stage. Staging is based on the number and location of affected nodes following the modified Ann Arbor system. While this disease has a good prognosis at low clinical stages, high-stage disease carries a far less favorable prognosis. Lymphocyte-predominant Hodgkin lymphoma is distinct from classic Hodgkin lymphoma. Notice the lack of classic in the name. It is an indolent disease with good prognosis and is not associated with EBV infection. The neoplastic cell is the so-called popcorn cell, resembling popcorn. Unlike the neoplastic cells in classic Hodgkin lymphoma, it retains the B-cell markers, such as CD20, and is negative for CD15 and CD30. By the end of this section, you will be able to describe the different sites of T-cell development, recognize the hallmark cell of anaplastic large cell lymphoma, and list the important characteristics of adult T-cell leukemia lymphoma. The last lymphoma group we'll discuss are the T-cell lymphomas, part of the non-Hodgkin lymphoma classification. T-cell development starts in the bone marrow with lymphoid progenitors that circulate and colonize the thymus. The earliest thymocyte is a precursor T-cell, negative for CD4 and CD8, double negative. As T-cells mature, they co-express CD4 and CD8, double positive, and eventually lose one, leading to either a CD4 helper T-cell or a CD8 cytotoxic T-cell. T lymphoblastic leukemia lymphoma develops at this stage, which is why T-ALL often presents as a mediastinal mass. Mature CD4 and CD8 positive T-cells are then released into the circulation to colonize peripheral lymphoid tissue, peripheral T-cells. Anaplastic large cell lymphoma, adult T-cell leukemia lymphoma, and angioimmunoblastic T-cell lymphoma develop in these sites and are termed peripheral T-cell lymphomas. Anaplastic large cell lymphoma, ALCL, is an aggressive T-cell lymphoma characterized by horseshoe-shaped hallmark cells with eccentric nuclei and prominent nucleoli. Similar to Reed-Sternberg cells of classic Hodgkin lymphoma, these cells are CD30 positive. Anaplastic lymphoma kinase, ALK, is positive in a proportion of cases associated with good prognosis in younger age. A common translocation in these cases is the translocation 2-5 that leads to fusion of NPM1 and ALK. ALK-negative cases are more common in older patients and carry a worse prognosis. Adult T-cell leukemia lymphoma is associated with the human T-cell lymphotrophic virus type 1, HTLV1, with a high prevalence in endemic areas including Japan and the Caribbean. An important laboratory finding is hypercalcemia, which is caused by secretion of cytokines stimulating osteoclasts to resorb bone. When the peripheral blood is involved, the characteristic cell is the polylobated flower cell, with the lobes looking like the petals of a flower. Angioimmunoblastic T-cell lymphoma is a nodal lymphoma derived from follicular helper T-cells. These specialized CD4-positive helper T-cells reside in the germinal center and provide help signals to help support B-cell survival. This T-cell lymphoma uniquely expresses germinal center markers CD10 and BCL6, expressed also by germinal center B-cells. AITL is an aggressive disease which usually presents in advanced stage, with B symptoms, generalized lymphadenopathy and/or hepatosplenomegaly, and skin rashes. The classic histologic findings is effacement of normal lymph node architecture by a polymorphous cellular infiltrate, with a background that includes abundant follicular dendritic cells and numerous small vessels. Medium-sized tumor cells often congregate in these areas and may have abundant clear, pale cytoplasm. Small lymphocytes, plasma cells, eosinophils, histiocytes, and scattered EBV-positive B cells are found in the background. The latter are thought to arise in the setting of depressed immunity associated with the underlying T-cell neoplasm. These B cells may resemble Reed-Sternberg cells and are termed RS-like, which is a potential pitfall. Patients are also at risk for developing secondary EBV-positive B-cell lymphomas, such as DLBCL and classic Hodgkin lymphoma. Cluster of differentiation nomenclature was proposed in 1982 and established a standardized system to categorize the rapidly growing list of monoclonal antibodies generated by different laboratories to study leukocytes' cell surface molecules. There are now over 300 CD markers, most acting as receptors or ligands involving the immune response. These markers may be upregulated or downregulated as cells mature, or in response to certain signals. Interrogating the expression pattern is of value to pathologists, since various hematopoietic cells and hematolymphoid neoplasms express unique combinations of these markers, which may aid in a diagnosis. Clinically, we study CD antigens by immunohistochemistry and by flow cytometry. Immunohistochemistry is performed in situ on formalin-fixed tissue sections. An antibody specific to a target antigen, like CD3, attaches to antigen-positive cells, like T cells, and is eventually labeled to be visualized. The second is flow cytometry, which is performed on unfixed viable cells. The methodology is similar to IHC, but requires a suspension of live cells labeled with fluorescent markers. Tissue architecture is lost. However, flow cytometry has the advantage of interrogating multiple surface markers simultaneously on many thousands of cells. The next two slides review markers commonly used in diagnostic hematopathology and can be used more as reference. CD2 is a transmembrane protein on T cells. CD3 is the signaling component of the T cell receptor complex and present on mature T cells and cytoplasmic and immature T cells. CD4 is a co-receptor for MHC class II found on T helper cells and monocytic cells. CD5 and CD7 are both T cell transmembrane proteins. CD8 is a co-receptor for MHC class I found on cytotoxic T cells and NK cells. CD10 is a zinc metalloprotease found on immature lymphocytes, germinal center B cells, T follicular helper T cells, and granulocytes. CD15, unlike the other protein molecules we've been discussing, is a carbohydrate adhesion molecule which mediates phagocytosis found on neutrophils and in classic Hodgkin lymphoma. CD19 is part of the B cell co-receptor and a common target for chimeric antigen receptor T cell therapy. CD20 is a transmembrane calcium channel found on B cells and therapeutically targeted by anti-CD20 antibodies such as rituximab. CD21 is a receptor for complement C3d and EBV, and present on follicular dendritic cells. CD23 is another follicular dendritic cell marker. CD21 and CD23 immunohistochemical stains are useful to highlight the FDC meshworks in a lymph node. CD30 plays a role in activation and is present on activated B cells and T cells, as well as some neoplastic cells such as Reed-Sternberg cells and Hallmark cells. CD34 is a stem cell marker found on immature hematopoietic precursor cells. CD45 is the leukocyte common antigen present on most hematopoietic cells. CD79A is part of the B-cell antigen receptor complex. CD117, or c-KIT, is a tyrosine kinase expressed on some progenitor cells and mast cells. CD138 is a cell adhesion molecule seen on plasma cells, epithelial cells, and some mesenchymal cells. The next set are cytoplasmic and nuclear proteins, not included in the original CD schema, which focused on surface proteins. BCL2 is an anti-apoptotic protein, which is turned off in germinal center B cells. T cells and mantle cell B cells are normally positive. Certain germinal center neoplasms may harbor translocations which aberrantly upregulate BCL2 expression, such as follicular lymphoma and diffuse large B-cell lymphoma. BCL6 is a transcription factor found in germinal center B cells and T follicular helper T cells. PAX5 is a B-cell lineage-specific transcription factor. This nuclear marker is especially helpful if a patient has received anti-CD20 therapy. MUM1 is a transcription factor commonly used for post-germinal center B cells and plasma cells. Cyclin D1, also known as BCL1, is a cell cycle regulator. It is found in a variety of neoplastic and non-neoplastic cells, including over 95% of mantle cell lymphomas. c-MYC is a proto-oncogene overexpressed in certain lymphomas, such as Burkitt lymphoma and DLBCL, secondary to translocations. ALK is a tyrosine kinase receptor, which may be expressed in a subset of ALCL. MPO is myeloperoxidase seen in granulocytes, especially neutrophils, and myeloblasts. TDT is seen in immature lymphoid cells, such as lymphoblasts, hematogones, which are normal immature lymphoid precursors in the bone marrow, and thymocytes, in the thymus. Ki67 is an index of proliferation. A high Ki67 is nonspecific and is seen in physiologic germinal centers, reactive conditions, as well as high-grade neoplasms. Another way to organize these markers is by cell type. This table highlights some important marker groups. In general, B cells are positive for CD markers higher than 10, including CD19, CD20, CD79A, PAX5, and the common leukocyte antigen CD45. T cells express low CD markers, CD2, CD3, CD4 or 8, CD5, CD7, BCL2, and the common leukocyte antigen CD45. Germinal centers contain germinal center B cells and T follicular helper T cells. In addition to expressing B and T cell markers, they express CD10 and BCL6. Germinal centers are negative for BCL2. Follicular dendritic cells are found within germinal centers and express CD21 and CD23. Plasma cells express CD138, CD79A, MUM1, with either kappa or lambda light chain restriction. Myeloblasts express MPO and the immature marker CD34, among others. Lymphoblasts express CD10, TDT, and the immature marker CD34. In addition, B-ALL expresses a variety of B-cell markers, and T-ALL expresses a variety of T-cell markers. A helpful way to classify lymphoid neoplasms, particularly those of B-cell derivation, is by their CD5 and CD10 expression profiles. Let's start by discussing the CD5 positive B-cell leukemia lymphomas. Remember, CD5 is normally expressed on T cells. Expression of CD5 by B cells is an aberrant finding, seen in two major CD5 positive B-cell neoplasms. The first and most common CD5 positive B-cell neoplasm is CLL-SLL. CLL-SLL is positive for CD23 and CD200. You can remember CD200 by CLL having two L's and 200 having two zeros. It is negative for cyclin D1 and FMC7. Those with mutated immunoglobulin variable heavy chain genes, a product of somatic hypermutation, have a better prognosis. Unmutated IGVH, originally thought to indicate pre-germinal center origin, have a worse prognosis. CD38 and ZAP70 are surrogate markers for mutational status. Both are positive in IGVH unmutated lymphomas, which carry a worse prognosis. The second CD5 positive B-cell neoplasm is mantle cell lymphoma. Remember, mantle cell lymphoma is characterized by the 1114 translocation involving cyclin D1 and the immunoglobulin heavy chain. The same translocation may be seen in some cases of multiple myeloma. Given the translocation, it is no surprise that mantle cell lymphoma is positive for cyclin D1. Other positive markers include SOX11 and FMC7. Remember, FMC is for mantle cell. Mantle cell lymphoma is negative for CD23 and CD200. Now let's discuss neoplasms negative for CD5. CD10 is helpful here. Remember, CD10 is a marker of germinal centers and is positive in physiologic germinal centers, as well as some neoplasms which may arise from the germinal center. CD10 positive neoplasms are commonly tested, but can be remembered by the mnemonic bad fall, which stands for Burkitt lymphoma, AITL, DLBCL, follicular lymphoma, and acute lymphoblastic leukemia lymphoma. Burkitt has a translocation involving MYC and IgH, so it's no surprise Burkitt lymphoma is strongly positive for c-MYC staining. AITL is unique to this category since it is a T-cell lymphoma, but remember, it arises from the special T follicular helper T-cell, which is native to germinal centers. DLBCL can be of germinal center origin and non-germinal center origin. Most germinal center origin DLBCLs retain CD10 expression. Follicular lymphoma has a translocation involving IgH and BCL2. This germinal center-derived lymphoma therefore expresses BCL2, which is absent in normal germinal centers. And lastly, acute lymphoblastic leukemia, both B and T cell derived, can be CD10 positive, since CD10 is expressed on immature lymphocytes. CD5 negative, CD10 negative neoplasms include marginal zone lymphoma, lymphoplasmacytic lymphoma, and hairy cell leukemia. The distinction between marginal zone lymphoma and lymphoplasmacytic lymphoma can be challenging, and a thorough clinical history and genetic profile is helpful. Most lymphoplasmacytic lymphomas harbor a MyD88 mutation. This mutation is a good marker, but is not specific, and may occasionally be seen in other tumors, including marginal zone lymphoma. Remember, hairy cell leukemia cells show characteristic cytoplasmic projections on peripheral blood smear. In addition, hairy cell leukemia is positive for CD11C, CD25, CD103, annexin A1, and BRAF. And just like that, another topic is mastered. It's time to save some virtual patients. Please complete the short exit quiz to test your understanding. Thank you for completing this module, and be sure to leave your feedback for future improvements. This course was developed and produced by Dr. Brad Drumheller. The scholarly education project was part of the 18-month medical education track directed and instructed by Drs. Ulema Luhanga and Taryn Taylor at Emory University. Review, edits, and support were provided by Dr. Dale Frank, Division of Hematopathology at the Hospital of the University of Pennsylvania.